lecture. Our first one is a 45-year-old woman who presents to her new primary care provider for an initial physical exam. She has no symptoms. Her blood pressure is in the office is 152/90, but she reports she often has high readings in medical settings. She has tried checking her blood pressure at home, but measurements have been erratic and inconsistent. What is an appropriate next step for this patient? This is kind of a guess what I'm thinking kind of question. I'll admit that. But okay, I'm hearing Charlie. Would that be the general consensus?
Yeah.
Correct. So this person is saying and dismissing her blood pressure as white coat hypertension. Now it's very easy as us as providers just to be like, okay, that makes sense, white coat hypertension. However, 152/90 is not like a borderline pressure, right? So we have to do due diligence to make sure that this patient in fact has white coat hypertension versus actually having true stage 2 hypertension according to the ACC/AHA guidelines, right? So how can we do that? Well, we have them do home blood pressure monitoring, but I gave you the information that she's done it in the past and it's been inconsistent and erratic and whatever, which means she's unreliable, right? So I can't get reliable blood pressures to confirm white coat hypertension. So I'm stuck with, well, let's get a 24-hour ambulatory blood pressure monitor. And so that's why Charlie is the correct answer. Plus, prescribe a beta blocker. Remember, beta blockers are not one of our first-line agents for hypertension, right? So that's not a reasonable option. B, I think we kind of hit, we don't want to ignore that elevated blood pressure. And then order a series of tests to assess for secondary causes of hypertension. Technically, we haven't diagnosed hypertension yet, so I can't go the next step in doing lab work to diagnose secondary hypertension, right? So, and she's not really in that at-risk age group that we talked about for secondary hypertension. So that leaves us with Charlie and why that's the correct answer. Our next one is a 35-year-old man presents to the primary care clinic for a follow-up of elevated blood pressure readings at his last 3 appointments. He denies any symptoms or significant past medical history. His father had hypertension and suffered a stroke at the age of 38. On exam, his blood pressure is 150/90 in both arms and 160 in his right calf. There are no murmurs or bruits. His laboratory evaluation is notable for a reduced serum potassium level of 3.3 with normal renal function testing. Which of the following secondary causes of hypertension is most likely? Kind of key things I'll point out is this. We talked about how it's secondary hypertension. If you see hypokalemia in hypertension, you got to think this. It's what my mom had or has.
Oh shit.
Primary aldosteronism. Remember, aldosterone acts on the sodium potassium ATPase pump in the distal convoluted tubule, and it causes the retention of sodium in water at the expense of dumping potassium. So you're getting rid of all this extra potassium unregulated, and so your potassium levels can drop in this condition. So primary aldosteronism is the answer for that. And then our last one is what's the definition of hypertensive urgency? Remember we had hypertensive crises, and under those were hypertensive urgency and hypertensive emergency. Do you remember what the definition was? So urgency with or without end organ damage? Okay, good. So we can rule out A, we can rule out delta, and now you're looking at these ranges. Well, 220, greater than 220/130, that's a pretty high, so it can't be that. And then the answer is actually, so these are the same, so you can't really delineate between those two. So then it comes down to what the diastolic pressures, and the answer is Charlie. Okay, so that blood pressure to meet that hypertensive crisis is systolics greater than or equal to 180, and diastolics greater than or equal to 120. Okay. So, all right. Here's just a funny little meme I found that's totally appropriate and relevant for this class today. So atherosclerosis, if you know Greek, you can kind of see what the pathology is. Unfortunately, we don't really teach Greek nowadays, right? But athero, or a theory, comes from the word of gruel or paste, okay? And then scleros is hardness. So a hardness from gruel or paste. So you can kind of see we already are describing what we're going to find in this condition simply by translating that Greek. And what's interesting about atherosclerosis is, yes, it's a condition of elevated cholesterol levels, but it ultimately is an inflammatory condition. There's got to be inflammation present to trigger a atherosclerotic plaque formation, okay? It's responsible for the majority of deaths in industrialized nations. Remember, we've talked about hypertension. We're going to be talking about ischemic heart disease tomorrow. And you'll see there's going to be a common thread with all of our lectures in this block where it comes down to hypertension and hyperlipidemia as risk factors for all of the pathologies that we're going to talk about in this block. But it doesn't affect just one artery. We normally are thinking of coronary arteries because of heart attacks, right? But it can affect the carotid arteries and cause somebody to be at risk for a stroke. It can affect the peripheral arteries, like in the lower extremities, where now people are having disruptions of blood flow to the muscles in the lower extremities. So now they can't walk, or they can't walk very far because they cannot keep up with the supply cannot keep up with the demand of oxygen and nutrients and stuff like that for those lower extremity muscles to function. When we look at the risk factors, there's going to be risk factors that we can't do anything about, right? I can't stop the aging process, at least not yet. Elon Musk is working on it, so we'll see in the next 20 years if that happens, but I highly doubt it. Male gender, okay? That puts somebody at risk. And then heredity. So if somebody has a genetic predisposition for something, I can only fight against genetics for so long before it finally wins. So those are things that we can't really change to reduce risk. But fortunately, there are so many other risk factors for atherosclerosis that I can actually change. I can do lifestyle changes to address these conditions, okay? So if they smoke, let's stop smoking. If they have elevated cholesterol because of poor dietary intake, well, let's fix your diet. If you're obese, let's fix that. If you have diabetes, let's hopefully maybe reverse you, or at least let's manage those sugars so they're not at the diabetic levels anymore. But when we look at atherosclerosis, it's important to know where is this occurring, because it's going to explain why this is a problem and why these can be so fragile, okay, and lead to an acute occlusion leading to a heart attack and those kinds of things. So when we look at the wall of the artery, there's three layers. The innermost layer is this intima, which is covered by a very small single layer of endothelial cells, okay? Doesn't really have much strength to it, but kind of just serves as like that dividing surface between the blood in the lumen of the artery and the muscles that regulate the tone of the artery. The media, or the middle layer right here, this is where all your smooth muscle cells are, and this is where your strength and your integrity of that artery comes from. But it also is where all the muscles are to regulate the tone and the systemic vascular resistance in the artery itself. And then the outer layer just kind of keeps everything together and supports the functions, and that's called the adventitia, but is not really a strong layer. It's just there to kind of support the artery itself. The endothelial layer, even though it's only a single layer, is actually one of the most vital, important layers there is because it has the ability to regulate inflammation. It's got antithrombic factors, so it reduces the chances of inflammatory response, clot formations, those types of things. But in the instance where there is damage that occurs and healing needs to occur, it also has those prothrombic factors that will allow for that inflammatory process to occur to heal the damage that is done. So the endothelial layer is important to regulate that immune response, that inflammatory response, so that you have appropriate inflammation when needed, and it stops inappropriate inflammation when it is not needed. Well, what can happen? So if I have an inflammatory trigger that occurs, then it starts to recruit all of these additional things like immune cells, muscle cells. It triggers the recruitment of that in order to cause that inflammatory process. And we'll illustrate kind of how this goes wrong over the course of the next couple of slides. But you don't go from a normal artery to an occlusive artery because of a plaque in a matter of hours or days even. This is something that develops chronically over time. And there's different stages that we will see in the development of this atherosclerotic plaque. The first part is the formation of a fatty streak, which we'll talk about. Then it goes into a plaque progression, where now you're getting this organized kind of plaque, more complex plaque. And then in severe cases, it can then go to a disruption of that plaque, and that's what leads to strokes. That's what leads to heart attacks and those kinds of things. So what exactly is the fatty streak? It's the earliest sign that atherosclerosis is developing. And what happens is, especially in conditions where you have elevated LDL circulating in your bloodstream, that when there is some kind of damage that occurs to the endothelial layer, that LDL can gain access to the intima. But the body recognizes that it shouldn't be there. So then it recruits immune cells, particularly monocytes, that then differentiate into macrophages. And what do macrophages do? They consume, right? Most of the time they're able to consume foreign things and then break it up and get rid of it, right? But when it comes to LDL, macrophages cannot break down LDLs. So what do? They sit there, they scavenge, they eat, they get bigger, bigger, can't break this down, can't break this down, can't break this down. They continue to eat, and then they explode. Which is what, is this Veruca salt from? It's not Veruca. Veruca is the golden goose, right? I can't remember her.
Violet Beauregard.
Violet, yeah, that's right. Violet Beauregard from Willy Wonka. But they break, well, what is inside of those immune cells when it ruptures? It has all these distress signals. They just popped. It thinks it's, it is dying, but it thinks it's under stress, so what is it going to do? It's going to release all these chemokines, cytokines that trigger even more of an inflammatory response because it needs help. So then other things start to move in. I.e., if I can't get rid of a foreign body, what do? I wall it off because I want to protect my body from this foreign body. So what does it do? Muscle cells, smooth muscle cells, move in from the media into the intimal layer, and they start to surround this LDL slash foam cell slash disrupted foam cell to kind of wall off and contain this foreign body so it doesn't do further damage. But the problem with that is that then starts to push into the lumen of this hollow structure, right? And starts to narrow that structure. It starts to interfere with that flow of blood, which then creates shear forces. And now that plaque can start to erode, and then it can lead to the exposure of prothrombotic factors, which then leads to an acute clot formation, which then could lead to a complete occlusion of that blood vessel, say the coronary artery, which then means you're having a heart attack. Okay, so that's the progression of an atherosclerotic plaque from just the LDL being deposited to then having this plaque disruption. And here's a cartoon version. So if you didn't understand or didn't like how I explained it, here's a cartoon version that shows you what we just talked about. So you have that LDL, it's existing in the blood. Let's say it's an elevated level. You get micro damage of the endothelial layer, it gets deposited into that intimal layer. Well, then that triggers these chemokines and cytokines to then recruit monocytes to come in. That monocyte is able to get through, it kind of wings its way through that endothelial layer, and then it starts to consume all this LDL that you see like right here. It consumes it, it can't break it down, it packs it away, gets bigger, 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 gets into these foam cells, it ruptures, and then the smooth muscle cells come in and start to kind of encircle it to contain it. Now you get your plaque formation there, and it's kind of protected, right? But now I'm including that lumen, and then if something happens, the shear forces or the body's own ability to kind of get rid of that plaque disrupts the plaque too much, you can then expose this prothrombotic core and then triggers that clot to form. And then it could occlude the artery. And here's just an example of that. So here's your plaque, or here's your atherosclerotic, here's the plaque part over it, it's occluding the lumen. You get a disruption of that plaque, which then triggers that clot to form and occlude that artery. But we said it can happen in any artery, anywhere in the body. And you can look at this list and it'll show you what are the different types of pathologies you may encounter and the cause of that. But ultimately it comes down to an atherosclerotic plaque formed. It either disrupted the blood flow locally, or a part of that broke off and then got sent downstream and then occluded an artery, leading to further pathology. And we'll talk about each of these conditions in this block. So let's look at the lipids themselves. So we know there are multiple types of lipids. You got HDLs, which is your good cholesterol, right? You got your triglycerides, which are kind of like the building blocks for bad cholesterol. You've got LDL, which is the bad cholesterol level, version of cholesterol, right? So we've got all these different things, but there's a rhyme and a reason in a normal system for all of these things to exist. HDL is kind of the scavenger of LDL, right? It's kind of trying to get rid of that LDL level. So we normally think of the higher your HDL, the better, because it's there. You have more HDL to go in and kind of get rid of LDLs as it forms. But that ultimately leads to, there are lots of different terms that we can apply to cholesterol disorders. And it's important that you know which term applies, because that's going to affect your diagnosis, right? You want to be able to speak the language appropriately, so we got to know when we throw out words like dyslipidemia, hyperlipidemia, what are we trying to specifically convey? So when I say dyslipidemia, what I am saying is that LDL level is elevated and that HDL level is down, okay? So dyslipidemia is elevated LDLs, low HDLs. When I say hyperlipidemia, I'm saying that the LDL levels are high and the triglyceride levels are high. When I say hypercholesterolemia, I'm saying that the total cholesterol is high. It doesn't matter if it's isolated to the LDL or the HDL or the triglyceride levels. It doesn't matter. It's just the overall total cholesterol is high. And then you can say you have hypertriglyceridemia, which just means that there's this isolated elevation of the triglyceride levels themselves. So let's look at hyperlipidemia. So what we're saying is you have an elevated LDL and triglyceride. And when we look at this specific condition, there is a primary cause, or primary causes, which means genetic causes. And then there is secondary causes, which is there's something else, some other condition that's causing this to be there, like obesity, poor lifestyle changes, other metabolic conditions like diabetes, thyroid disease, all those things can lead to that. And that's secondary causes. And secondary causes are more common in the United States or in other industrialized nations than primary causes, okay? But when we look at primary or genetic causes for this, there's two main types that we gotta consider. The first is this familial hypercholesterolemia, where, according to genetics, there is a LDL receptor gene mutation so that I cannot utilize LDL appropriately. So what ends up happening is because I'm not utilizing that LDL, that means it just sits there and it circulates, uncontrolled. And now that can lead to deposition of LDL into the intima layers of the arteries, leading to premature atherosclerotic cardiovascular disease. And a lot of times you actually will see physical exam findings of this, and we'll show examples of each of these physical exam findings over the next couple of slides. But you can actually diagnose somebody with high cholesterol, specifically a familial cause, if you were to see these physical exam findings in your patient. The other genetic cause is familial combined hyperlipidemia, which shows elevated triglycerides and LDL because of a genetic component to it. And that also can lead to premature coronary arterial disease or atherosclerotic disease. Here's the list of things that can cause secondary hyperlipidemia. Some things make sense. Medications can also do this, so be careful. And other things can cause and contribute to this. But what's interesting is, okay, does it make sense that if I'm obese or I have weight gain, that's probably going to cause an elevated LDL level, right? But look what else can cause an elevated LDL level. So I've got the spectrums. Either I'm too heavy or I am too light, and I'm not consuming, right? Well, why is it that anorexia can cause elevated LDL levels? It's a severe nutritional deficiency, right? I may be eating 100 calories a day for an extended period of time, right? Well, what is the body going to do if it's not getting the nutrients it needs? Stockpile, or it's going to start shutting down processes that it deems are not important. Is heartbeat important? Yes. Is breathing important? Yes. Is LDL scavenging important? No. We're going to shut that one down. In your female patients, menstrual cycle, shuts down because you're trying to preserve nutrients because you're in such a severe nutritional deficiency. So you'll see in your anorexics, those LDL levels are going to be high, and it's because that system is shut down. Okay? Now look at the bottom here. Pregnancy can cause elevated LDLs. And so don't test cholesterol in your pregnant patients because you're not going to act on it, first of all. But two, the reason that LDL is high in pregnant patients is progesterone triggers the release of LDL. That LDL circles around to the placenta, which then is utilized to make more progesterone, which then is used to sustain the pregnancy, right? So this is a feedback mechanism to try to preserve a pregnancy by continuing to produce progesterone. Now, this is different, and these LDL levels are different because you're using that LDL, right? In situations where you're not utilizing that elevated LDL level, that leads to those microvascular changes and everything like that because you're not utilizing that LDL. But in pregnancy, you are utilizing, it's kind of this self-perpetuating concentration because it wants to sustain that pregnancy until birth, and it does that by the progesterone. But I need to make the progesterone. I need those compounds necessary to make progesterone, which LDL is part of that. So interesting things to see for different reasons why that LDL could be elevated. So how are you going to approach your patient if you diagnose them or suspect they have hyperlipidemia? Similar to anything else or any other patient, you're going to do your history and you're going to do your physical exam. And you're going to assess for risk factors. What makes you at risk of having further morbidity and mortality from this? Okay? We got to know, well, what is their cholesterol level? And once I get that data, I need to know what that risk equates to. I need an objective calculation to then go and tell my patient, or that objective calculation to influence my treatment and my management of this condition, okay? And then you're going to determine, once you get all that data, what's the next steps? You got to follow up with them. So looking at history, USPSTF has recommendations on when to screen patients for cholesterol. In an average risk person, men 35 and older, women 40 and older, okay? Or if there are risk factors, then you may want to do it earlier. But we're going to talk about some of the treatment conundrums that we encounter because the ASCVD risk calculator that we're going to talk about, that you're going to be tested on, starts at age 40. But if my first test is 35 for a normal at-risk male, what do I do from that 35 to 40 range? Because my treatment algorithm doesn't kick in until 40. Okay, so when we'll talk about in the FYI slide, a new thing that actually will address that concern. Now, part of your history is you're going to assess, does this person have clinical atherosclerotic cardiovascular disease? So have they had a heart attack? Do they have ischemic heart disease? Have they had a stroke? Do they have peripheral arterial disease? These are diseases that are specifically caused by atherosclerosis. Have they had these happen before? If they have, that's going to influence our treatment and our management for those patients. Then you're going to do your physical exam. And there's a number of physical exam findings that you can see in your patients with hyperlipidemia, especially if it is profound elevated LDL levels. The first is these xanthomas, which is a couple of different versions of it. The eruptive xanthoma almost looks like whiteheads or like a really bad acne, right? But look at that picture. There's not really a surrounding erythema around it. And when you look closely, that's not a whitehead. It's not white. It's actually yellow. And that is LDL. So you actually are seeing LDL in the skin. Because it's got to pack it away somewhere, because you have such a severe elevation of this LDL. It's got to put it somewhere, and the skin can see that. Then you can have tendinous xanthomas, which are these firm nodules that you'll see on kind of the tendons, the extensor tendons of the hands and the Achilles. So these firm nodules actually are LDL being packed into that tendon. Then you can have tuberous xanthomas, which almost kind of look like a warty kind of look, or like condyloma or something like that. And these can be present on the elbows and the knees, but these have a yellowish appearance. Again, you're seeing that LDL, so it gives you that yellowish appearance. And then the next thing you can see is xanthelasma, which is this yellow kind of deposition that occurs around the eyes. And that again is from LDL or excessive LDL being placed in that tissue layer. And then the last physical exam finding that you might find is corneal arcus or arcus senilis, where you see this yellow kind of ring deposited in the cornea. That is LDL, cholesterol. Although when we talk about rings around the eyes, we immediately think of Kaiser-Fleischer rings with elevated copper in Wilson's disease. This is not the same thing. And you can see I put a big X on it. It's brownish in appearance. That ring in the Kaiser-Fleischer ring is brown. This is yellow. Okay? So that's what kind of differentiates copper deposition versus LDL deposition in the cornea or in the iris itself. Okay? Then we're going to want to do labs, because we want to see exactly where our LDL or our cholesterol levels are, because that's going to help us determine treatment, right? So you're going to do fasting labs, so you're going to look at their lipids. You're going to want to look at their liver function, because you're going to need that kind of information when you start thinking about medication management. You're going to want to get a hemoglobin A1C to test for diabetes, because that's part of the risk calculation, is if they have a history of diabetes. And then you're going to want to get their creatinine kinase because of the potential side effect and complications related to statin therapies on that. So you want to see what their baselines are before they start any kind of medications to treat cholesterol. And you can see in this picture, I don't know if I have any former lab techs in here, but when you draw blood, it's all the layers, all the things are going to be mixed. When I centrifuge it and I spit it down, all those cells drop to the bottom, and now I'm left with this plasma on the top, which is like your fluid layer, right? This is what it should look like. But somebody who has hypercholesterolemia or hyperlipidemia, you actually get all this cholesterol deposited in that plasma. And you look at that, it's like mayonnaise circulating in your blood. Imagine the consequences of having mayonnaise circulating around your blood. Okay. We're not doing, fortunately, Hollywood hasn't come up with mayonnaise IVs for treatments for things. So we don't have this yet. But that's basically what is happening in your patients with hyperlipidemia. Now, we used to really focus on numbers when it came to treatment, okay? So the way you calculate total cholesterol is you actually take your LDL levels, you add your HDL levels, and then you take the product of triglycerides divided by 5, you add all those three numbers together, and that gives you your total cholesterol level, okay? And then we used to then look and be like, oh, your total cholesterol is greater than 200. We got to start treating you. this is, if my total cholesterol is greater than 200, well, why is it? Is it because my LDL levels are high? Okay, then yes, maybe I do need treatment. Is it because my triglyceride levels are really high? Okay, yeah, maybe I do need treatment. But what if it's because my HDL levels are really good, which is causing my total cholesterol to be high? Where, like, let's say your HDL is 100, your LDL is 70, and your triglycerides are 150. That will put you over 200. So does that person really need treatment for having elevated good cholesterol? So you can see kind of how this treatment recommendation, or focusing on numbers specifically, wasn't really the appropriate approach to take in the management of cholesterol. So then back in like 2017, 2018 timeframe, American College of Cardiologists came up with this atherosclerotic cardiovascular disease risk calculator, okay? And what was nice about this is I didn't look at an isolated value. I actually took the patient as a whole and then came up with a risk calculation with it. So I was looking at, well, what's their age? A 20-year-old with a total cholesterol of 200 is going to be very different than a 80-year-old with a total cholesterol of 200, right? Then I also look at, well, what's their gender? What's their race? What's their blood pressure look? So you can start seeing looking at risk factors for cardiovascular disease, right? What might make somebody high risk, to include smoking history. And then, once I put in all those things, I then get 3 different values, that objective values, that I can then take to my patient and talk to them about their risk of heart disease or cardiovascular disease. So the first value you're going to get is, in 10 years, what's your risk of having an atherosclerotic cardiovascular event? I put in just some patient variables in this calculation. You can see this person has a 33.3% chance, 1 in 3 in 10 years, they're going to have a heart attack, they're going to have a stroke, or they're going to have symptomatic peripheral arterial disease because of atherosclerosis. Okay? So that can be a scary number, but let's say that this number is actually like 6%. Okay, not a scary number, but the second value I can get is, what is your lifetime risk? So this person has a 2/3 chance that they're going to, in their lifetime, have a cardiovascular event. So now you're in that position of, hey, you're a smoker, you have a 2 out of 3 chance that you're going to have an event in your lifetime. Maybe we should start thinking about quitting smoking. Maybe we should start to eat healthy. Maybe we should start working on losing that weight and getting out of the obese range. Okay. And then if they're still like, oh, well, you know, there's not much I can do about this, the third number you get with that cardiovascular calculator is, what's your optimal risk? So based on your non-modifiable factors, so your age, your gender, right? If I fix all the things that can be managed or adjusted, changed, what is your risk? So in this patient, if I were to treat their blood pressure, control their hypertension, stop them smoking, they have a 2.1% risk of having an event in the next 10 years. So this is really where you're getting your bang for your buck in your counseling of your patients, because you can say, look, right now you have a 1 in 3 chance in the next 10 years you're going to have an event. If I were to optimize everything, I could get you down to a 2.1% risk. That delta between those may be enough to inspire the patient to start making the lifestyle changes that they need in order to manage their cholesterol. But yes, lifestyle modifications is important, but let's just say that you have a patient who needs medications to treat their LDL levels. What do we have at our disposal? You're going to be tested on this tomorrow, right? So our for lifestyle changes, there's lots of things that they can do. And in fact, when you look at it, you can see what is the expected drops in the different values if they make these changes. And these are listed kind of as themselves, but if I were to do 2 or 3 of these lifestyle changes, those would add to each other as far as the expected change in their LDL levels or their HDL levels or their triglyceride levels. So look at what we can do. Well, let's reduce our calories, especially calories from refined sugars and carbohydrates. I can expect up to a 20% decrease in my triglycerides simply by doing that. Let's reduce our saturated fats to less than 7% of our total calories. 8 to 15% drop in your LDL by making that change. Replace some saturated fats with unsaturated fats, especially polyunsaturated, another drop of about 10%. Reduce my dietary cholesterol to less than 200 milligrams a day, and you can see all of these things add up and lead to a pretty significant decrease in LDL levels, to the extent where if I have a low intensity statin, I may do better with lifestyle changes than with that medication. But let's say they do need statins, or they do need a medication. Statins are our best oral medication to reduce LDLs, okay? And study after study after study has shown it reduces major coronary events, it reduces coronary arterial disease mortality, it reduces strokes, and it reduces coronary procedures. So we have evidence statins achieve the goal of putting them on those medications, because I'm improving morbidity and I'm improving mortality rates from cardiovascular events. But statins do have risks associated with them, right? We all know about the muscle side effects. And these muscle side effects could be just muscle aches in general, but it could be moderate or even severe problems. So you can get myopathy, which is defined by muscle pain or soreness, okay, same as this, right? Except you have an elevated serum creatinine level that's greater than the upper limit of normal. So you have an increase in the creatinine kinase levels, right, above normal. The severe form of the side effects is rhabdo, which now you're having a significant, severe increase in your creatinine kinase levels, and you have an elevated serum creatinine. So this tells me that the kidneys, the function of the kidneys are being disrupted by this muscle breakdown, okay? So that's the severe form of statin therapy, or adverse events from statin therapy. So what are you going to do if you were to encounter somebody who is experiencing muscle aches? Well, first of all, stop the statin, at least temporarily, and look for reasons that this might be happening. Let's classify. Is this myalgias? Is this myopathy? Or is this rhabdo? So get those lab tests to kind of see. And then once you get that, then if it's just mild to moderate, then you could either start them on the same statin, but maybe at a lower dose, or maybe change them to a different statin and see how they tolerate that statin. Just because you had this reaction to one statin does not mean you'll have the same reaction to all statins, okay? If it is severe, then that's a different story. We probably don't want them on a statin at all. But when we look at the treatment algorithms, it talks about high-intensity statins and moderate-intensity statins. And you got to know what the dosages are of the different statins that would make you be prescribing this patient high-intensity versus moderate-intensity, okay? And I will make it easy on you that you don't need to know these. Nobody really prescribes those. And You don't need to know these because they don't really work. So,
Not according to farm.
there was a farm instructor 2 years ago when I first started teaching this that made the junior class at the time stand up, put their right hand up, and swear an oath that they would never prescribe simvastatin to any of their patients. Okay, so that makes it easy because now you're down to 2 statins: atorvastatin and rosuvastatin. These are great because their dosages are in the high intensity or the moderate intensity, depending on which dose you put them on. But what's also nice about this is these statins you don't need to take at a particular time of day. You can take them any time of day and it will work. All the other statins, you have to take them at bedtime to get full benefit, full effect of this. So atorvastatin, rosuvastatin are the best. Study after study after study have shown that these two work the best at getting the expected outcomes. Now, you may be asking, well, why is it high intensity versus moderate intensity? And what really kind of differentiates that is, what is my expected drop in LDL based on the dosage that I put them on? If I'm putting them on these high intensity dosages, I'm expecting at a minimum 50% reduction in their LDL. At a minimum, 50%. If I put them on a moderate intensity, I'm looking at about a 30 to 49% reduction in their LDL levels. Okay? So that will help you when we start talking about management and goals and stuff like that. It will help you determine what the expected outcome should be, so you kind of have an idea of what your goal is for that patient based on the statin you choose. But what else do we have at our disposal? So we do have Zetia, or ezetimibe, which this works different than the HMG-CoA reductase inhibitors, blah, blah, blah. This actually blocks the intestinal absorption of cholesterol from food you eat. So now I'm not absorbing those LDLs out of that Big Mac that I just ate, right? Maybe not all of it, but what's interesting is in isolation, the effect on reducing your LDL is similar to a low intensity statin. Okay? But based on our current guidelines, typically we don't give this as a monotherapy. We usually give this as an adjunctive therapy, preferably to statins, because we may not have gotten to our goal with that statin dose. Let me add this other agent that works differently from the statin to try to get them down to goal. And then I'm just going to talk about this and then we'll break for our break. The PCSK9 inhibitors are really the latest drug on the market for treating cholesterol. And studies after studies have shown that patients respond very well to these things. It is highly effective at reducing your LDL levels. It's highly effective at improving morbidity and mortality from atherosclerotic cardiovascular events. So you may be wondering, why is this not a primary thing, and why is statin therapy emphasized over PCSK9 inhibitors if it's well tolerated and has the clinical benefit that we want? Ultimately, it comes down to price. Okay? Imagine if you're an insurance company, would you want your patient to be on a medication that costs you $90 for 3 months, or a medication that costs you $3,600 for 3 months? What do you think they're going to want you to be on? That's really what it comes down to. PCSK9 inhibitors are expensive. It's about $1,200 a dose for it. And you get them like once a month. And they work great. But again, $1,200 versus $20, $30 for that statin therapy. You know, what is more effective? What can your patient actually afford? So PCSK9 inhibitors are really reserved for patients who either have a severe reaction to statins and cannot be on a statin, so they have rhabdo from their statins, or they are on a max dose statin, they're on Zetia, and they're not at goal. Then we'll put them on a PCSK9 inhibitor. Okay? And insurances, if you can document those things, most insurance companies will then pay for the PCSK9 inhibitor. Okay. And that includes TRICARE. So even for your active duty folks, TRICARE will refuse your prescription unless you can document these things. Okay? So don't think that active duty military are immune to those things. There is a approval process, especially for these expensive medications. So let's go ahead and take 10 minutes, come back at 9:02, and we'll finish up.
Yeah.
Right? It's like, I think that's played.
I feel like you can still ask, like, small stuff.
I wish you could. I'm saying that it's an actual application.
Cinnamon protein,
You know that song?
Take it down there.
Oh, it was good. I said I got 8. I'm starting Friday.
Mine likes to fluctuate between 140 and under 100. Like I can tell you that when I'm stressed, I'm like shit, it goes up back up to 140. And for some reason, it like plateaus at 140, goes back down.
But it went up in the last 2 years.
But also, look at the calculator. Like, I put myself into the actual calculator and like put my risk at like 140. I don't know.
The one right now.
Yeah, and like honestly, I'm like barely at
When I see that it gives you below theory, I'm like,
but it's not also
They have higher than
because yeah, like people who eat a lot of red, sure. But it's not always like you know actually it says on there like you know how like that actually causes a spike up. It's not like that's a fact. I never really like I was reading just about how much syrup and last I'm just that's a lot. Like shrimp are so low calorie.
I'm gonna tell you right now, t-shirts
but they haven't passed it.
they only have 8 questions. She's got like 4 of them.
You know what?
Medication. You need to know this, but it's like, she makes me nervous.
Should we break this?
I blocked it. And I looked to try to send me a picture. I told her to send me a picture. Ask her if it's recording.
Oh, you can see.
Well, it doesn't
Can
load.
you see?
I didn't
It
know
says
that.
it didn't load. So I just saw like a picture.
I just thought like you just no longer meant this. I don't think I actually want more.
That's the meta.
That's like going to the. Oh yeah, yeah. Yeah, that's so
They said for me to be faster. They did drink coffee.
That's fine. As long as coffee doesn't have black coffee.
No, I think
Yeah. So man was
Said Jesse Holiday and taking that dude off in a deep one.
All right, I got 9:02 on the clock. Let's get back to it. So we just finished talking about the medications that we can use to manage LDL levels. If you look, or if you notice, we didn't really talk about triglyceride levels. We'll talk about that at the end of this lecture. But we just focused on LDLs. And when it comes to treating elevated LDL levels, when you look at the treatment algorithms, you have to make the decision, is this patient, and am I treating this patient for primary prevention or secondary prevention? That's the first question you have to ask yourself. So what does that mean? So primary prevention is somebody who's never had a cardiovascular event that I'm trying to prevent them from having their first one, okay? That's primary prevention. Secondary prevention is a patient has had a cardiovascular event, whether it be a stroke or heart attack or symptomatic peripheral arterial disease, and I am now trying to prevent it from recurring or the development of an additional one. So, for instance, they've had a heart attack before. Now I'm treating them to prevent them, one, from having another heart attack, but two, prevent them from having a stroke as well. Okay? So that is the difference between a primary prevention and secondary prevention. Okay? And once you've answered that question, you can then look at your treatment algorithms. Okay? And that will help you determine how you treat and manage this patient. Now, can't help you for tomorrow's test, but in my test, I will give you this algorithm. Okay? So, don't spend your time, for my class, for your farm tomorrow, yes, my class, don't spend your time studying and memorizing the LDL treatment algorithm. And I do this for a couple of reasons. One, by the time you start practicing, this probably is going to change. Two, you're not really going to be tested too much on the pants about cholesterol management specifically. You may be more like along the lines of, you want to do a high-intensity statin, which dose do you choose? Or it's going to be pretty obvious, hey, this person just had a heart attack and has all these risk factors, put them on a high-intensity statin. You know. So they're not going to ask specifics. Now, the other reason I give you this algorithm is I would rather you spend your time learning how to follow along the algorithm so you can manage your patients appropriately, okay? So instead of focusing on memorizing the data, I want you to learn how to utilize the data, okay? This also then affords me the opportunity to kind of test you on the subtle nuances of the different steps because I want to make sure you understand not all patients are the same. There are going to be some patients where you may need to treat them more aggressively, and that information is on this algorithm, okay? I'm not going to make it up. It's on the algorithm. You just have to read the fine print, okay? So that's why I will give you this algorithm on my test. Tomorrow, no luck. So, looking at this algorithm, so we're going to do a deep dive into this algorithm and learn how to actually manage and utilize this. So, so the first question we said we had to answer is, do they have clinical ASCVD? And let's say they do not have clinical ASCVD, so no. Your next question is, okay, this is primary prevention. Is this patient's age 40 to 75? Okay, the answer is yes. Okay. The next question is, well, what's their LDL level? And you can divide them into three categories. Their LDL is less than 70, their LDL is greater than or equal to 190, or they're in this borderline range of 70 to 189. So you got to stratify your patients into one of those three categories in that primary prevention. So what do we do if our LDL for our patient in primary prevention is less than 70? Well, calculate risk factors, lifetime risk, all these other things, manage those so they remain low. And they never get put into a category where potentially those values will put them at high risk. If LDL is greater than or equal to 190, then it says start them on maximal tolerated statin. So kind of think of it as you're putting them on high intensity statin. Whether it be the lower range or the higher range, it's a high intensity, and ultimately you want to get them to as high of a dose as they can tolerate. Okay. And once we get them on that maximally tolerated dose, then my goal is I want their LDL less than 100. It says if greater than or equal to 100, then add ezetimibe. Okay? So the inverse is true too, where if their LDL is less than 100, you're at goal. But if we don't get their LDL less than 100, we're not at goal, so we need to add things. So add ezetimibe, which you can get maybe up to another 20% reduction in their LDL levels with ezetimibe. If, after putting them on maximally tolerated statin and ezetimibe, they are still not less than 100, then it says put them on a PCSK9 inhibitor. Okay. So if we don't get to goal on our other treatments, put them on PCSK9. Okay. Does that make sense? So patient with LDLs greater than or equal to 190, the goal is less than 100. But if you notice, what's interesting is, did we ask the question for the greater than 190, did we ask the question if they have diabetes or not? The answer is no. Diabetes does not play a factor in how we are going to treat and manage that patient if their LDL is greater than or equal to 190. Okay? Diabetes does not play a factor. It does play a factor when we're in that borderline range where your LDL is between 70 and 189. This is where diabetes and that diabetes history is important because it's going to influence your treatment goal for that patient. Okay? So it says, start them on a moderate intensity statin, aim for an LDL lowering of 30 to 49%, which is the expected reduction of LDL if you put them on a moderate intensity statin. Okay? So that's kind of your goal is 30 to 49%, but that's also the expected outcome with a moderate intensity. But there is a caveat in the fine print here that says if they have multiple ASCVD risk factors or ages 50 to 75, high intensity. So if they're at high risk, yes, today they have not had a heart attack. But if I can be like, based on your risk factors, in a year from now you're going to have a heart attack, maybe I need to be a lot more aggressive in my treatment for them. Okay? And if you put them on a high intensity statin, because they're high risk or have all those comorbidities or they're older, then I would expect at least a 50% reduction in their LDL with that high intensity statin. Okay. But let's go back up in the algorithm, and instead of saying yes, this patient has diabetes, let's say that they do not have diabetes. Now I am using my ASCVD risk calculator, and I am now calculating what is their risk in the next 10 years of having an event. And if they are less than 5%, then lifestyle risk discussion. If they are 5 to 7.5%, they are considered borderline risk. Discuss risks for statins, or look at their risk enhancers, and then make the decision on lifestyle versus actually putting them on a moderate intensity statin. So if they have other risk factors, but they otherwise are low risk or borderline risk for having a disease in the next 10 years, then maybe they would benefit from having a moderate intensity statin. So what are our risk enhancers? So if you look at it, okay, family history of premature ASCVD. Okay, makes sense. Persistently elevated LDL greater than 160. Metabolic syndrome. Persistently elevated triglycerides. Lipid protein A levels. All of those are risk enhancers. And just from my personal medical history, I had 2 of these factors, and where I had LDL of like 160 something a couple of years ago, and then last year I had it repeated and I was 170. So I didn't meet that 190 or greater to warrant being very high, but I had these persistently elevated levels despite exercising, eating healthy, losing weight, and such. So my provider decided that she was going to test my lipid protein A levels, and lo and behold, they came back double the normal. So now I had elevated lipid protein A. So now you kind of think of it as I have a genetic disposition for elevated cholesterol. She became concerned enough because of that she did a coronary CT or a cardiac CT that showed plaque calcifications in the proximal portion of my LAD, which is why I had to do the stress test on Monday. But, Monday or Tuesday, whatever that day was, Tuesday. But that then prompted her to start me on medications, because when you look at my family history, my grandfather just dropped suddenly of sudden cardiac arrest at the age of 72, and my paternal uncle died at 56 of sudden cardiac arrest. We didn't have or didn't know about lipoprotein A, but looking back at everything, and probably what happened is they had plaque formation in the LAD and had that event occur that led to Widowmaker being occluded and led to 2 widows, okay, in their personal family history. So, even though, and the reason that these are risk enhancers, if you were to put all of my data into the ASCVD risk calculator, I was at 2.5% risk of having an ASCVD event in the next 10 years. So you would have thought just lifestyle changes will follow up, right? But because of family history, because of that persistent severe elevations in LDL, despite lifestyle changes, it prompted the evaluation and looking into other causes of it that ultimately is causing premature coronary arterial disease. Okay, so make sure you're looking at your patient's histories and not solely focusing on ASCVD risk. Okay. So going back, so we talked about your borderline risk. Let's look at how you treat a intermediate risk, or the ASCVD calculation of 7.5 to 20%. This range is, in my opinion, is probably too broad, but I'm not a cardiologist, so I can't tell them that. But, so what does it say? Look at risk enhancers, do coronary artery calcium scoring, treat them with moderate intensity statin and lifestyle with a goal of 30 to 49% reduction in their LDL levels. Because I'm putting them on a moderate intensity statin, I expect a 30 to 49% reduction in LDL. And then the last category is ASCVD is greater than 20%. So this is somebody who is high risk. If they are high risk, does it make sense that we probably should put them on a high intensity statin and expect at least a reduction of 50% in their LDL levels? That's primary prevention. So let's look at secondary prevention. So these folks have had at least one cardiovascular event that is attributable to an atherosclerotic plaque, okay? And the first thing you gotta ask when you look at the algorithm is this patient considered very high risk or stable? And what makes that patient very high risk is if they've had 2 or more major ASCVD events. So they've had a heart attack, they've had a stroke, or they have symptomatic peripheral arterial disease. So if they have 2 of those, then automatically they're considered very high risk. But if they've only had 1 of those things, so they've just had a heart attack and that's it, you gotta look at some of the other high risk conditions, which kind of makes sense when you look at them or consider them. They're old, okay? Well, that makes sense if they're elderly, that they're going to be at high risk of having another event. They have other conditions, diabetes, hypertension, they currently smoke, persistently elevated LDLs, history of congestive heart failure. So other diseases that would put somebody at risk of developing another heart attack, another stroke, or another persistent symptomatic arterial disease. If you have 2, it says multiple, but really that's like 2 or more. So if you have somebody who has diabetes and hypertension and they've had a heart attack, they are considered very high risk. Okay. So when we look back at our algorithm, you can see, okay, very high risk. Now what's interesting, secondary prevention, the age is now 18 or older, not 40 like it was for primary prevention. So 18 or older, you start them on maximally tolerated statin. Okay? So maximal tolerated statin with a goal of getting their LDL less than 70. If it's greater than or equal to 70, they are not at goal. So then, in addition to that maximally tolerated statin, we are then adding ezetimibe. And then we bring them back a couple months later, and we check their LDL levels again. And if it still is greater than 70, they are still not at goal, and then we got to put them on a PCSK9 inhibitor. Okay. So for somebody very high risk, secondary prevention, the goal is get their LDL less than 70. But let's say that they've had a heart attack and maybe they're just hypertensive, but they don't have any other high-risk conditions. And now they qualify as a stable ASCVD. That doesn't mean that they will never have another event. It just means that right now it's stable. And you look at the treatment recommendations for these patients, and you can see we're not as aggressive, okay? Because it says you can do either a high-intensity statin or a moderate intensity. So you get a choice. However, your goal is going to be different depending on the dosage you choose. Okay? So if I choose a high-intensity statin and they only get a 35-40% reduction in their LDL, I did not get to goal. Okay? So I should probably add ezetimibe. If I put them on a moderate intensity statin and they get to 35-40% reduction, I did get to goal. So I don't need that additional medication to get them to goal. Okay? So your goal in a stable ASCVD secondary prevention patient is really dependent on if you choose to put them on high intensity or you choose to put them on low intensity. And you may be asking, well, what makes you want to do high intensity versus moderate intensity? Really talk to the patient and kind of see, well, what are their thoughts, okay? But when we look at our very high risk conditions, let's say you have a 64-year-old whose birthday is next month, who's had a heart attack and has hypertension. you can see in 1 month, they will now have 2 high-risk conditions and an ASCVD event. So now they actually would be considered very high risk, right? So maybe that might prompt you to go ahead with the high-intensity statin because they're going to change their category by the next time you see them. Okay. So what's in the future for us? Well, for one, we've identified that our calculator is not, it's better than what it was, but it's not really accurate. And so they've come up with this new calculator, which is called the Prevent Risk Calculator, which when we do our lab for this block, I'll bring that up and kind of show you the difference. And what's good about this one is it gives you a 10-year estimate and a 30-year estimate. So I'm 40, what are the chances that by the time I'm 50 I'm going to have an event? Versus I'm 40 and by the time I'm 70, what's the chances of me having an event? The other thing that's nice is, remember, we said primary prevention on the ASCVD starts at age 40, but I want to start testing men at 35. So the Prevent calculator actually includes or goes down to 30-year-olds. So now I can capture that patient and be able to properly manage and treat those folks. The other thing that we found was it overemphasized race. So if you were African American, you automatically replaced very high risk. Okay? But what we found was, and the Prevent calculator actually accommodates this, is actually race is not the greatest factor in cardiovascular disease. The greatest factor is your zip code. Because what goes along with zip code? Probably how much money you've got, right? What's the access and the ability to afford it to good, healthy, nutritious foods? Do you have an HEB in your zip code? Or do you have to travel 20 minutes to the closest grocery store? So you now are relying on fast food chains to give you your food. Okay? So we found we overemphasized race with the ASCVD risk when really, it's really your zip code that portends to bad outcomes. Because I guess the other reason zip code's a problem is what's the access to a medical facility to take care of your problems, right? If we're in an urban area like we are here, yes, you might have to deal with traffic, but you probably could get to a provider's office or a hospital or something to get stuff taken care of. However, if I'm 3 hours away in the middle of nowhere, what's the likelihood I could get to a provider's office to get my blood pressure taken care of, or get my diabetes taken care of, or get diagnosed with hypercholesterolemia? Okay. So the Prevent calculator requires you to put in the patient's zip code to come up with a calculation. Other things in the future is going to be treatment guidelines for high lipoprotein A patients. Okay. For instance, myself with high lipoprotein A, there's really no good guidance on how you manage this. Part of that's because we also don't have medications to specifically treat lipoprotein A. Okay, all we've got is statins, and I will tell you, I got put on rosuvastatin 20, so a high-intensity statin, and my cholesterol levels dropped from 174 to 65. So I had more than 50% reduction in my LDL by being put on that high-intensity statin. Okay. So, but that's the best we've got. It doesn't address the lipoprotein A circulation levels. So yes, my LDL levels might be good, but what's the lipoprotein A doing? So I'm not getting rid of that. Okay. And then other things I foresee is, we consider high HDL levels as a good thing, right? But is there a level where it's too high? And some studies have actually shown, like if you have an HDL greater than 100, it actually can cause cardiovascular events. So there's more to come. And that, if that is found to be true, then the question is, well, how do we manage this, right? What are the things that normally raise your HDL? Eating fruits and vegetables, eating low fats, exercising, having an occasional glass of wine. All those things can raise HDL. So what am I going to do? Become a couch potato, get obese, get fat, raise your HDL or LDL levels, and lower your HDL. Is that a good alternative? So we got, how do you manage somebody if we're found to have significant elevations in HDL? How do we manage those patients but still prevent cardiovascular events from happening on the other side? Okay. So more to come, and in your time practicing as a PA, these questions will be answered. Okay, so that's the LDL side of the house when we talk about hyperlipidemia. Okay, but remember, hyperlipidemia was elevated LDL and elevated triglycerides, right? So what do we do when you have a patient who has elevated triglycerides? So we say normal triglycerides is less than 150, but a moderate hypertriglyceridemia is if you have a value of like 175 to 499. Some literature will say 151 to 499. So you have an elevation, moderate elevation. Then you have severe hypertriglyceridemia, which is when you have a value that is greater than 500. Okay? Those are the two categories you really need to concern yourself for in this. And severe hypertriglyceridemia, when you start getting those values above 500, it actually increases your risk of pancreatitis. Okay? Have you had GI yet? And talked about the pancreas yet? When you start talking about acute pancreatitis, the acronym for things that cause acute pancreatitis is bad shit. Okay? You'll remember that? That's how I always remember it. But part of that is the H part is hypertriglyceridemia. So the S is scorpions from Tobago. So always remember that one. That's a great one to know. But yeah, scorpion stings. But a specific scorpion from Tobago can cause acute pancreatitis. So, yeah. All right. So hypertriglyceridemia. Most of the time, we just need to do lifestyle changes, and that should address the elevated triglyceride levels. If it's moderate, lifestyle changes. That is the treatment, is lifestyle changes. So values of 151 to 499, lifestyle changes. Easy day, right? It's not until they get above 500 that we now recommend a medication specifically to address their triglyceride levels. Okay. So what do we have at our disposal? The most common one is going to be your fibrates, like fenofibrate. And you can see you get a pretty good reduction in the values of the triglycerides with fenofibrate. Although gemfibrozole is probably the better one, or at least has the most clinically improvement. But if you look at the second to the bottom bullet there, somebody who's on a statin and gemfibrozole is at a higher risk of having rhabdo as a side effect of the statin. So you never want to have that patient on a statin and gemfibrozole. You want to have them on statin fenofibrate. Okay. So how do they work? Well, it's a PPAR alpha agonist. Will hastens the removal of chylomicrons and VLDLs from the plasma. Okay, great. I'm not concerned too much about that. Farm tomorrow, maybe they'll be concerned about that. But But what I am concerned about is it is considered the best for lowering your triglycerides. It's good for raising HDL. And ultimately, it's good at reducing the formation or progression of coronary arterial lesions. So I have a good clinical effect of treating severe hypertriglyceridemia with fenofibrates. Okay. What else could you do? So niacin, you could do it too. That does have some benefit to it. We normally kind of think of this as we need to boost a isolated low HDL level. We'll give high doses of niacin. But this is a poorly tolerated medication at the dosages that you need in order to actually have any kind of clinical effect. The one is the flushing. These folks will turn beet red and they will feel like their skin is on fire as a side effect from B3. Okay? So not really tolerated, although it does have clinical benefit, not very well tolerated at the dosages necessary to treat this condition. Omega-3s, we're not sure how and why this might work, but this might be an option, especially if your patients want to do natural things. This might be an option that you can tell them to do, just to let them know. They may have some GI distress, they may have some increased burping and those kinds of things as a side effect of it, but these are typically otherwise pretty tolerated, pretty well tolerated, and it can have some benefit to it. But ultimately, lifestyle changes for the vast majority of your patients with hypertriglyceridemia is going to be the treatment of choice. Okay, and you can look at, okay, if I'm looking at the triglyceride levels, a lot of that is going to be weight loss and eating a healthy diet. And your recommended caloric intake of all the different things, you can kind of see here, okay? Less than 7% of total calories should be from saturated fats. Up to 10% of total calories should be polyunsaturated. Up to 20% should be monosaturated. But total fat content should be 25 to 35%. Okay. But let's talk about one of the risk enhancers for cardiovascular disease, and that's metabolic syndrome. And to be able to be officially diagnosed with metabolic syndrome, you need to have 3 of the following. Abdominal obesity, men, if it's greater than 40. Women, it's greater than 35. I don't have any Navy folks in here, but prior to the end of December when our new BCA guidelines came out, we would do, if you didn't make height weight, we would do single site circumference. And these were the values that you were graded on because it's supposed to be a healthy force. If a male had an abdominal circumference less than 40, they were considered healthy or healthier. Women, it had to be less than 35 inches. I had some concern about this because me having a 40-inch waist versus a 4'0" person having a 40-inch waist would look like a Oompa Loompa, right? So I didn't think it went far enough. So now, of course, all the services are doing this whole height to waist ratio measurements things, right? I think the Army went to that, right? And I think the Air Force did too. Navy officially went to that in the end of December when the message came out, but yeah. So, metabolic syndrome, one of the criteria is abdominal circumference. The next criteria is triglycerides greater than 150. So basically, is it above normal? HDL, if you have a male, it's less than 40, or female, less than 50. That is a criteria for metabolic syndrome. And then let's look at their blood pressure. According to ACC-AHA guidelines, if they are stage 1 hypertension, then they are considered as one of the criteria for metabolic syndrome. And then fasting glucose greater than 110. Not necessarily in the diabetic range, but you're in that impaired fasting glucose range there's some kind of disruption in glucose metabolization. But ultimately, treat with lifestyle choices or lifestyle changes as much as you can. Get them exercising, get them eating healthy, stop their smoking, drinking alcohol appropriately, and that will decrease cardiovascular risks. Because ultimately, what we talked about today, in 90% of your patients, is a primary care problem. You all in this room will be managing these types of patients, and you will have the opportunity to affect their life 10, 20, 30 years from now by the choices you make today. Preferably, actually, the choices they make today based on how you counsel them and talk to them and those types of things. But this is a problem that they're not going to know something is wrong until it's too late. They've had their heart attack, they've had their stroke, or they cannot walk up a flight of stairs because their legs cramp up because it's not getting the oxygen it needs. Okay. So this is our problem in primary care, that we can have significant impact on their life decades from now. So on that, that's all I've got. Questions? Yeah. It is actually, and actually above 190, we're just trying to get them less than 100 is the treatment goals. So let's say they're 191, and I put them on a high intensity statin. I'm expecting at least a 50% reduction. 50% is going to be what, 89-ish, if I'm doing my math right. So I should get them down to less than 100 with that max dose. Now, if they have LDL 240, now if I only get that minimum 50% reduction in that high intensity, now I'm looking at like 120, I'm still not below 100. So I may need to add something else to get them that last little bit. But remember, the expected LDL reduction is not just 50%. It's greater than or equal to 50%. So like in my personal history, I haven't done the exact calculation, but I went from 170, 175 to 65. That's more than 50%. And that's what you can anticipate in your patients once you put them on a high intensity statin. Yeah, if you need like three treatments because you need PCSK9 and ezetimibe and statin, yes. If they don't get to goal, you're kind of stuck because you don't really have anything else to add on to it. So you can say, look, I'm maxing dosing everything, and they're still not getting the goal. That's when you got to have that lifestyle choice because they're still doing McDonald's or whatever. Any other questions?
In primary treatment, we're talking hyperlipidemia. Less than 40 gets found to be having high LDLs. Is there a situation where the LDL warrants starting a statin before 40, or is it all just focused on lifestyle?
Yes. So there is a level, and this is where that Prevent, that new calculator that just came out like a year ago, really comes in because that can get you into less than 30. And that can calculate ASCVD risks for that. So, so there is a situation. So that algorithm is based off of a standard of care guidelines that's about 180 pages long. And one of the instances where the 40 doesn't really tick into it or doesn't really matter is if they're 35, 36, and you do their LDL and it's greater than 190, you're starting them on statin therapy. But that's, you have to delve into the guidelines to actually look at that special case scenario. Any other questions? Yeah, for like the weight loss reduction standpoint, and potentially also if they're having like a or impaired fasting glucose, having some benefit from there. There is opportunities for it depending on insurance or if they can afford a GLP. Yeah, because there is clinical benefit by losing weight. There is clinical benefit by preventing the progression to diabetes from that pre-diabetes or that impaired fasting glucose, whichever term you want to use for it. There is benefit, long-term benefit by doing that, but you got to justify it to the insurance company, or you got to justify it to the patient to pay out that money every month for that GLP-1. Yeah. Do I suspect GLP-1s would become better utilized? Absolutely. Once they get cheaper. So, yeah. And unfortunately, it's not necessarily the medication that's expensive. It's the dumb auto-injectors at the pharmaceutical companies, going back to your question from yesterday, or 2 days ago. It's the auto-injectors that the pharmaceutical companies package their things in for convenience that costs so much. So if you were just to take that medication out of that auto-injector and just use normal syringes, small fraction of the price. Talking about maybe $150 to $200 for that GLP-1 dose versus $1,000, $1,200. So there is room for pharmaceutical companies just want to put lots of money in their pockets. All right,